Hello, and welcome to One World, One Health, where we chat with people working to solve some of the biggest problems facing our world. I'm Maggie Fox. This podcast is brought to you by the One Health Trust, with bite-sized insights into ways to help address challenges such as infectious diseases, climate change, and pollution. A One Health approach recognizes that we're all connected: animals, plants and people, and the climate and environment. Cancer is a scary diagnosis. Even though many cancers are now much easier to treat and cure, people still dread getting the diagnosis, and the treatment can be complex. And cancer often isn't even what kills a patient. The second leading killer of cancer patients is, in fact, an infection. More and more often, those infections are caused by drug-resistant organisms, what's known as antimicrobial resistance, or AMR. Although we know it's happening more frequently, not many people are tracking just how often it does occur. One of those people is Dr. Yehuda Marte, an assistant professor of medicine at the Hospital of the University of Pennsylvania. She and colleagues set out to see just how commonly these drug-resistant superbugs were affecting cancer patients compared to other people getting treated as outpatients. They found that drug-resistant infections were 3 times more common in cancer patients than in other people getting outpatient treatment in the U.S. For inpatients, people being treated in the hospital, it's about twice as often. We're chatting with Dr. Marte in this episode to talk about the problem, how it arises, and what can be done about it. Yehuda, thanks so much for joining us.
Thank you very much.
Why are cancer patients at such a higher risk of infection in general?
So there are multiple reasons why cancer patients are more prone to infections, and some of it is related to the cancer itself, and some of it is related to the treatment that we give for the cancer to cure it or to manage it. And so when we think about cancers that affect the body's immune function to be able to produce immune cells to fight off infection, things like leukemia and lymphoma, which we call hematologic malignancies, impair the body's ability to do this. And so it makes cancer patients with these tumors, with these cancers, more prone to having infections. Additionally, therapies that we give to treat cancer can damage the bone marrow. And so typically we think about chemotherapy or radiation therapy, and these can damage the bone marrow, which makes specific cells that help fight bacterial infections. And so something that we call neutrophils can be very low in patients who are receiving chemotherapy. And when these are low, it also impairs the ability to be able to fight infection. Another reason might be because cancer patients just undergo a lot of procedures. And so whether it's surgery, whether it's insertion of IV lines or urinary catheters, all of these introduction of foreign bodies impairs the body's ability to, have a physical barrier against infection. Other side effects can also damage the gut lining and also cause cancer patients to have a higher risk of having translocation of germs that can cause infection.
And then why would they have a higher risk of a drug-resistant infection in particular?
So I think by mere fact that cancer patients do have a higher risk of infection in general, they do receive a lot of antibiotics, either for preventing infections or for treating infections. And the more antibiotics you get exposed to and the longer duration of antibiotics that you have, there's a higher risk of developing infections. There's also the fact that cancer patients tend to have more contact with the healthcare system. And so they end up having more frequent appointments in the outpatient setting, as well as admissions, either for treatment of their cancer or inpatient admissions for complications of their cancer. And so they do receive antibiotics during this period, which can then predispose them to having resistant organisms during subsequent admissions or subsequent contact with the healthcare system.
And that's something we need to talk about because, unfortunately, hospitals are supposed to be clean places. They've also become places where you can acquire these drug-resistant organisms. It's a place where they live and grow.
Yeah, I think it's sort of a double-edged sword in that people who are really sick get admitted to the hospital. And so I think resistant organisms are required. So one of the things that our data showed is that even though historically we think about hospital systems as being higher risk for acquisition of drug-resistant organisms, data in the Lancet Oncology show that patients on the outpatient setting, so patients who are just attending the clinic or are being treated in the outpatient, also have an increased risk of being exposed to resistant organisms. And so I think as much as hospitals play a role in this, I think there's also just the broad recognition that antimicrobial resistance is becoming more prevalent, even in the community and outpatient setting.
Now, you've done a lot of your work in the US. Do you have any ideas about what's going on in the rest of the world?
So I do. So part of my work that is not antimicrobial resistance related is actually looking at cancer outcomes in low resource settings. And I do a lot of my work in sub-Saharan Africa, currently work in Botswana, which is in Southern Africa. And so even though this work is based in the US, I think what we can infer based on just the prevalence of antimicrobial resistance in low resource settings is that it's likely to be much worse in lower resource settings. And so I do see patients in Botswana, for instance, where patients are not only diagnosed with cancer, but also have a high risk or a high prevalence of HIV. And so when patients present with infections, the type of infections that they can acquire are a combination of risk factors related to their cancer immunosuppression, but then they're also their HIV immunosuppression. So I actually think it's a bit more complicated to treat cancer patients in low resource settings. I think based on multiple factors like poor infection control, so sanitation, access to clean water, and then also lack of vaccination, poor access to diagnostics and antimicrobial medicines, I think we are likely to see more higher risk of antimicrobial resistance in cancer patients compared to our data. And so I think if you're thinking broadly about what this data means in terms of extrapolating to low resource settings, I think it's most likely that resistance is much worse than we reported in our data in the US.
So you're not just a numbers person, you are also directly treating patients. So cancer is really hard to fight all on its own without adding this extra burden for patients and the care team. Tell us what this means. What have you seen?
So I do think it's really challenging to treat cancer patients with infection. And I think it's challenging for the care team, and it's also challenging for the patients and their families. And so, in terms of our ability to deliver high quality care, having an infection disrupts care significantly. So, a patient who is infected has to have adequate infection control before you can administer chemotherapy, because you can make them significantly worse by administering therapy while they still have an infection. And so, definitely had cases here in the US and also in Botswana that illustrate this. I think maybe the differences are really in the care team and availability of specialists to guide their treatment. But patients who have multiple infections with resistant organisms have a higher risk of being admitted to the intensive care unit. They end up having a prolonged stay. And in most cases, you hold their cancer therapies. And it's really distressing for families, because cancer is a big diagnosis and you're ready to get treated and fight this, quote unquote. And then you end up encountering an infection. And it seems like the team isn't doing anything for your cancer. But what infection does is really sort of pull the brakes on how well you can administer cancer treatment. And so it causes several delays in treatment. In few cases, it can be fatal, especially in low resource settings where access to antibiotics in some cases might not even be guaranteed.
I mean, it's obviously fatal. It's the second leading cause of death for cancer patients. So it's got to be the worst. Somebody could possibly be cured of their cancer, but the darn infection comes in and kills them.
Absolutely, absolutely. And I think that is one of the reasons why I think there needs to be a wider recognition of the global health crisis of this within the oncology community. I think we've been very siloed in medicine and thinking about, subspecialty focus. And so AMR sort of falls within the realm of infectious disease doctors. I think given the fact that our patients are at risk for AMR, are at risk for fatal complications from this, and the fact that a lot of the therapies that we give are actually predicated on having adequate infection control, this should really be sort of a policy education issue that's highly prioritized within the oncology community. And it's not, I don't think there's a lack of recognition of AMR. We send cultures all the time. We do know what this data looks like on an individual patient level. I think there's just the lack of global acknowledgement that there is a crisis that significantly impacts our population, and we should really be involved in how we come up with solutions to address this.
Now, some of the newer cancer treatments, the way they're described to the public is that they rev up the immune system to fight cancer. Is this a sort of thing that could help cancer patients fight off infections as well?
That's a bit of a complicated question. It's a logical progression of thought, but it's complicated in that although the immune system is revved up, I think it's logical to think that, some infections might have better control because of a more heightened immune system. But increasingly, even patients who get immunotherapy get it in combination with other immunosuppressive regimens. And so you'd still get immunotherapy, but at some point during your treatment course, you might receive just standard chemotherapy or radiation therapy. And so I think there are still combinations of treatment that still predispose you to the infection risk.
Well, it's kind of tailored to the cancer, right? You're training the immune cells to recognize cancer, not to recognize an infection, right?
Exactly. So it's modulated in that it's trained specifically to detect or rev up the immune system towards the cancer. Sometimes when you rev up the immune system, you actually also cause the immune system to attack the patient's organs, or this is a side effect of the therapy. And so patients might develop inflammation of the liver or of the gut or lung toxicity that might then require steroids to suppress the immune system, which increases the risk. It's just a lot more complicated, but definitely a good thought in terms of rev up the immune system. I think there are definitely opportunities for research into thinking about how the immune system itself can help fight infections specifically, but cancer immunotherapy might not be sort of the natural remedy for AMR.
You note that very few people have done the kind of surveillance that you're doing. Why not?
So I have asked myself that as well. I'm an oncologist, and so I don't really think about AMR surveillance as my primary research focus. I think what's really unique about this study was the partnership that came together and then also access to this database that has samples from cancer patients and non-cancer patients from multiple institutions around the US. I think that was one of the huge strengths of this study. I do believe that there are smaller studies out there that are institution based. And so a lot of institutions, or almost all institutions, have electronic medical record systems. And so this data is being fed into systems all the time. And so I think on a hospital based level, this data can be generated. These analyses should be frequently generated to assess sort of regional trends or hospital trends and resistance. But I think being able to do this sort of multi-institutional, national scale study is unique. And the challenges might be in sort of how the data is collected and whether there are common metrics that can be synthesized across different institutions as organically as it is in this database that we used.
So, what are some of the solutions there might be? Is just having more and better drugs? Is it keeping patients away from any potential sources of infection or multiple things?
So multiple things, and I think you hit on some of the important ones. I think there's really a need for really good infection control. Then simple things like hand hygiene and also isolation protocols, and really great in academic institutions, but not available in all community practices. I think there's also a need for really good antimicrobial stewardship. And so when we prescribe antibiotics, sometimes you start with empiric antibiotics, which means you make a good guess of what the bug might respond to. But then within 48 hours, you have culture data. So these are samples either of blood or urine that you take to the lab. And so we should really be quick to tailor our antibiotics based on what this data tells us. And so if it's resistant, we change our antibiotics. If our antibiotics are too broad and we can narrow it down, we should de-escalate. And so having that antimicrobial stewardship in place is important. I think in the outpatient setting is where there is also a need to really focus on the diagnostic stewardship. We do prescribe easily within the outpatient setting, but calling patients to follow up when their culture data comes back and figuring out whether you need to change the antibiotic regimen is important. I think also educating patients on the duration of antibiotics, why it's being prescribed is important. Sometimes you start antibiotics that are supposed to be taken for 7 days and the patient feels great after 3 days and they stop. But really emphasize on the importance of the duration, the increased risk of resistance with misuse or improper use is important for patients to know as well. You touched on one thing, which is sort of the research component. I think there is a huge need to develop the research pipeline for antibiotics. And an example, like in which I frame this, is thinking about the cancer drug pipeline. I think there are more than 1,000 new drugs in the cancer research and development pipeline. And this is compared to just, less than 100 for antibiotics. And when you think about the global health crisis of AMR resistance, this is wholly inadequate and unmatched to the potential threat of AMR. And so I think there's definitely a need for investments in that. And it requires also multi-stakeholder partnerships to make these investments in this kind of research because it's high risk as well. I think as oncologists, AMR should be a problem that we prioritize because we treat our patients holistically. And so this is not just an infectious disease problem. It's our problem because our patients get infected often.
Yehuda, thank you so much for taking the time to chat with us.
Thank you so much for having me. It was great chatting with you. Thank you.
Listeners, if you enjoyed this podcast, please share it. You can find links to this and other important topics at onehealthtrust.org. And let us know what else you'd like to hear about at OWOH@onehealthtrust.org. Thanks for listening.
Thank you for listening to One World, One Health, brought to you by the One Health Trust. I'm Ramanan Lakshminarayan, founder and president of the One Health Trust. You can subscribe to One World, One Health on Spotify, Apple Podcasts, or wherever you listen to podcasts. Follow us on social media at One Health Trust, one word, for updates on One World, One Health and the latest in research on One Health issues like drug resistance, disease spillovers, and the social determinants of health. Finally, please do consider donating to the One Health Trust to support this podcast and other initiatives and research that help us promote health and well-being worldwide. Until next time.